Dr. Akhil Goyal, please.
Good afternoon, everybody. I'm Dr. Akhil Goyal from Department of Anesthesia and Critical Care, Armed Forces Medical College, Pune. Today I'll be speaking on ultrasound-guided paravertebral block, a comparison with the landmark-based technique. The aim and objectives of my study were to compare the efficacy of the ultrasound-guided paravertebral block versus the anatomy-based landmark technique with respect to the success rate, the time required to perform the block, hemodynamic variation and complications associated, if any. This is a prospective randomized control study which was carried out at our tertiary care teaching hospital at Pune between December 2011 to March 2013. And it included patients aged 18 to 17 years of ASA grade 1, 2, 3 undergoing elective unilateral breast surgeries. The exclusion criteria for the study are shown on the slide. Initially, approval from the Institutional Ethical Committee was taken, which was followed by a written informed consent taken from all the 80 patients. These 80 patients were then randomized using opaque sealed envelopes into two groups of 40 each. Group A was the ultrasound-guided group and Group B was the anatomical landmark-based technique. The block was given in the sitting position using the other technique at T4 level using a 18 gauge Tohoe's needle. The loss of resistance range was also used along with the Tohoe's needle in Group B. 3 cm length of the 20 gauge catheter was then left in situ. This slide shows the ultrasound machine, which is Sonosite Titan, which was used to perform the block. Initially, a test dose of 3 ml of 2% lignocaine was given with 1:2 lakh epinephrine, after which an initial bolus dose of 0.2 ml per kg of 0.5% bupivacaine was given over a period of 1 minute. Then a continuous infusion of 0.25% bupivacaine at the rate of 0.15 ml per kg per hour was started and continued intraoperatively. The time taken to perform the block was noted. Then hemodynamic monitoring with respect to the heart rate, the systolic and the diastolic blood pressure was carried out in both the groups starting from baseline at 5 minutes, 15 minutes and every 10 minutes thereafter till the first 1 hour after performing the block. General anesthesia was given as per the following protocol. Pre-medication consisted of glycopyrrolate, midazolam, ondansetron and fentanyl in the doses as shown. After that, the patient was induced with propofol in a dose of 2 to 3 mg per kg and the patient was intubated with an endotracheal tube with veterinary in a dose of 0.1 mg per kg. The maintenance of anesthesia was done with oxygen and nitrous in a ratio of 1:2 with isoflurane 0.6 to 1%, keeping the MAC at 1 with intermittent doses of vecuronium if required. The end-tidal CO2 was maintained between 34 to 38 millimeters of mercury and the reversal was given using neostitin and glycopyrrolate in the standard doses. Rescue analgesia if required was given with injection morphine 50 mg per kg plus minus the injection paracetamol 1 gram IV. The block was considered to be successful if the patient remained hemodynamically stable, if there was no rise in the heart rate on surgical incision and if no intraoperative opioid or paracetamol supplementation was required. Post-operatively, all patients received 0.1% bupivacaine at the rate of 0.1 ml per kg per hour for 48 hours, after which the paravertebral catheter was removed. The statistical data was analyzed using the SPSS version 17 software and the data was recorded in MS Excel worksheet. A sample size of 40 in each group was calculating considering the power of study to be 80% and a confidence level of 95%. All the data was analyzed using the appropriate non-parametric statistical tests. This slide shows us performing the paravertebral block in our pre-op room, taking the aseptic precautions. In this we are using the parasagittal in-plane approach. This slide shows us the sonoanatomy of the paravertebral space. In this we can over here we can see in the first slide the transverse process, the rib and the paravertebral space which lies deep to the superior costotransverse ligament. In the second slide we can see, in the second image we can see the two transverse processes and the pleura. Above the pleura, superficial to it is the paravertebral space. The demographic data was recorded in both the groups with respect to the mean age in years, the mean weight, the duration of the surgery and the type of surgery. The demographic data was statistically same in both the groups. The success rate in group A was 95% as compared to a success rate of 82.5% in group B, whereas the time required to perform the block under ultrasound guidance was significantly higher and the p-value was significant, less than 0.001. Whereas the incidence of complications which included vascular punctures and hypertension in our study the incidence was statistically similar in both the groups. This graph shows the variation of the mean systolic blood pressure in both the groups taken at various time intervals. As we can see, the mean systolic blood pressure variation in both groups is almost similar. Same can be said for the mean diastolic blood pressure taken at various time intervals in both the groups, which is also the same. And similarly, the heart rate in both the groups at the various time intervals has remained more or less the same. In the subgroup analysis of group A, the initial 20 cases required about a time of 848 seconds to perform the block, which reduced marginally by another 11 seconds in the next 20 cases. Whereas in group B, the initial 20 and the next 20 cases, the time taken to perform the block was almost the same. There was a 95% success with the ultrasound with 2 failures on account of hypotension and opioid stroke paracetamol supplementation, whereas the success rate with the landmark-based technique was 85% with total of 7 failures. This success rate was higher with the ultrasound, but however it was not statistically significant with a p-value of 0.07. Ultrasound use accurately locates the paravertebral space and enables us real-time observation of the local anesthetic, leading to improved success rate and reduction in the number of complications. The mean time required to perform ultrasound guided block was significantly more, and the p-value for the same was significant, being less than 0.001. Paravertebral block normally requires about 5 to 15 minutes to perform. The hemodynamic variation with respect to the heart rate, systolic and diastolic blood pressures in both the groups was same with a p-value of more than 0.05. There was a reduction in complications with ultrasound guidance. However, this reduction was not statistically significant. The limitation of the study was the blinding was not done as it was not possible. The efficacy of the block was assessed by the same anesthesiologist who performed the block, and there is a definite learning curve which has to be achieved before one becomes proficient in the block. To conclude, I can say that the ultrasound guidance improves the success rate, but it is time consuming. It reduces the incidence of complications, and there is no difference in the hemodynamic variation. However, both the improvement in the success and reduction in the number of complications was not statistically significant in my study. As more experience is gained with the use of ultrasonography, the time required to perform the ultrasound guided paravertebral block is likely to reduce. Thank you.
Did you test the blocks as soon as you have injected the main dose for sensory block?
Yes, madam, we had checked whether the effect was there. This was done by using an ether swab, which was used to check whether there is any loss of sensation or whether there is if there is a loss of sensation or not. Usually, it took about 15 minutes for the effect to come after giving the initial bolus dose. But we did not record with respect to the dermatomal level that how many dermatomes were the loss of sensation or the sensory block was in how many dermatomes.
Did you test it during the post-operative infusion with 0.1% bupivacaine? Was there any perceptible block?
Ma'am, we have started a post-op infusion of 0.1% bupivacaine, but we have not measured the VAS scores post-operatively. This study was to test the efficacy of the paravertebral block based on the intra-op parameters. However, because we have injected the catheter, and so that is why we have started with an infusion post-op, and this has been continued for 48 hours.
Did you inject all the drug through the catheter, or did you inject some through the needle and some through the catheter?
Ma'am, the initial bolus dose was injected through the needle, and after that we injected the catheter, and then the continuous infusion was started through an infusion pump through the catheter. And post-op we have started with an infusion or a Baxter infusion pump.
I may have missed in your presentation, what's the definition of success here?
So the block was said to be successful if the patient remained hemodynamically stable. There was the vitals remained stable. Secondly, if there was no increase in the heart rate on giving surgical incision. If there was tachycardia, then it was thought that the block was not effective. And thirdly, the MAC was after general anesthesia kept at 1 throughout. And thirdly, if the patient required intra-op supplementation either with the morphine or with paracetamol or combined.
Did you show the opioid consumption intra-op to show that one group is better than the other in terms
Sir,
of
I didn't understand the question, sir.
the intra-op opioid use? Did you present the data to show that one group is
Yes, sir.
less than the other?
Yes, sir. In the first group, there has been one instance in which intra-op opioid has been used, and in the second group, there have been 5 cases in which intra-op. I have shown the data in the screen.
Yeah.
5 cases have been used, sir. But they have been counted as failures.
So ultimately, success is dependent on the operator. How experienced are the operators for both techniques?
So prior to this starting the study, we had done about 15 cases of paravertebral block under ultrasound guidance, and that is why I have said that one of the limitations is that there is a learning curve which it takes a considerable amount of time before one becomes proficient. That is why the time taken to perform the block in the first group, that is the ultrasound guidance, is more.
But then for the landmark approach, those were proficient, experienced operators. Were they not? For the other group that used landmark approach?
Yes, sir. For the landmark based approach, we were experienced. We had given about 30-35 blocks, sir, and we were more experienced in it.
So in a way, you show a remarkable result. Even you're learning ultrasound, you're doing better than the landmark approach.
So yes, sir, the ultrasound approach is better because we have taken more time to perform it. And that is why the result is bound to be better if we see the direct injection of the drug under ultrasound. That is why
you'll always see the difference. There's no, I don't believe that with the scanning, your time to do the block with ultrasound will be shorter than the landmark because you do a lot more scanning and that requires time to do it.
it was 95% versus 82.5%. Yes, sir, it is clinic. That is correct, sir. We had taken a feasible sample size initially considering the success rate to be ultrasound in the ultrasound group to be 100% and in the other group to be 80%, and considering the alpha error of 0.05 and a beta and the power of study to be 80%, we had found out the sample size to be 40, which was a feasible sample size to be achieved in our setting. That is why the results are not statistically significant. Had we taken a sample size of more than 54 patients in each group and had the results been seen percentage-wise, then the study would have been statistically significant also. The results would have been statistically significant also.
Were all the blocks performed by the same operator or operator from the same class, I mean the seniority wise?
Well, the blocks were performed by me and along with my guide Colonel Navdeep Sethi. All the blocks were performed by both of us only.
Thank you. Thank you, Dr. Akhil.